and welcome to this third episode of the Clinical Corner. The topic of the day is full physiology challenges, a comprehensive approach. My name is Marco Toselli from Maria Cecilia Hospital, and I'm honored to host this session with two esteemed colleagues and dear friends, Andrea Marrone, our young operator, and the expert Simone Biscaglia, both from Ferrara University. So the Clinical Corner is an interactive format for all the young interventionists. So we encourage you to actually participate. Just scan the QR code to access selected material on full physiology. During the discussion, feel free to type a question in the chat or raise your hand and ask a question live. And if you missed our previous episode, you can catch up by watching them on YouTube. This episode will be available on demand next week. So, and last but not least, if you would like to present your case in a future episode, just send us an email. So let's start with the topic of the day. Andrea, I give you the word, and what case do you have selected for us today?
Thank you, Marco, for your presentation, and thank you everybody for being here with us early in this morning. Today we're gonna present a clinical case of a 68-year-old man with classical cardiovascular risk factor and without any prior cardiological history. We started complaining over the last month some effort chest pain, which was associated with palpitation and evidence on the EKG of monomorphic VEB. That's the reason he was admitted to another hospital in order to perform a coronary angiography. And as we can see here, coronary angiography showed an intermediate stenosis of mid-LAD without any other stenosis on L6 and just with some mild disease on the RCA. He was discharged with the indication of optical medical therapy. This patient, of course, kept on complaining chest pain and palpitation after the discharge, and for this reason, was told to go for some other investigations, just like the 24-hour ECG monitoring that showed a high burden of VEB, almost 10% of all the QRS complexes, with also a short run of an SVT, and also cardiac MRI and a treadmill test. As we can see here, cardiac MRI did not show any sort of late gadolinium enhancement and did not show any structural or functional abnormalities. And the treadmill test revealed just an SVT at the effort as the upper point of the effort. So, given all this data, all this new data, the patient was referred to our attention, and of course we decided to bring it back to the cath lab in order to better understand and evaluate this intermediate lesion on the LAD. This was his therapy before hospital admission. As we can see, he was on aspirin, valsartan, statin, and beta blockers. So we brought the patient back to the cath lab, and of course we could see the same lesion that we were expecting. And at this point, we had to decide what to do and what to go for next. So Simone, can you tell us something more about this decision?
Yes, Andrea, thank you very much for inviting me. So I would have two main comments at this point of the case. The first one is that it's funny because in stable settings, so chronic coronary syndrome, when we have to perform PCI, we are very keen to evaluate patient-reported outcomes, how is the patient feeling, the quality of life, angina, angina questionnaire. But then when we at the cath lab, we don't see any lesion to be stented, then you see, as in this case, basically, we forget about everything else that is not what we do every day. I am the first one to do so I'm not complaining about others. But in this case, I think it's interesting because this patient is wandering through different hospitals with basically always the same symptoms. And what was offered to him up to now was just angiography. And a reassurance that was not a diagnosis. So this is, I think, my second point. I think that in 2024, for an interventional cardiologist, it's not possible to perform an invasive assessment that doesn't end into a diagnosis. That can be also nothing is wrong from the cardiac side or from the coronary side and the whole circulation of the heart. So, but if we, I think that every time a patient get out of a cath lab without a diagnosis or worse, with the other tests to be performed outside of the cath lab in order to perform a diagnosis, I think this is a huge defeat for the whole interventional community. So I think that in this case, the idea is that we cannot go again by saying to the patient, don't worry, you may have some, some chest pain, but it's not related, also because this patient has non-sustained ventricular tachycardia. So, and the cardiac magnetic resonance is normal. So we have to understand and to do something more. I think that, so is the first point is angiography enough? Obviously not. Is a single point FFR, IFR, QFR, whatever you want to do enough to tell the patient you are okay? I think not. Again, because you will focus on 5% of the coronary circulation and not 100% of it. So I think, again, what we should think about in this case is to provide the patient a broader evaluation of coronary physiology and of the function of coronary artery in the overall. So I think that probably, Andrea, we will see what you did. I hope you didn't stop at the angio, otherwise I would kill myself, but we'll see.
Yes, Simone. Of course, we went for full physiology assessment of this intermediate lesion on the mid LCA, on the mid LAD, I'm sorry. And so here is our, approach for undergoing full physiology assessment. Of course, in these cases, we want to evaluate both epicardial vessels and microvascular and both structural and functional disease. So we usually go for epicardial assessment firstly with the non-hyperemic indexes at first, and then we usually go for hyperemia. And after this, we usually go for microvascular disease assessment with IMR and CFR. And of course, we also perform some intracoronary acetylcholine provocation tests to see if there is some epicardial vasomotor disorder. And what is really important is that if we perform PCI, we should repeat our assessment after PCI in order to see if our work has been enough. And as we can see here the pressure guide, which is downstream in the coronary artery. And on the right, we can see the non-hyperemic index, RFR, with a value of 0.94, which is really negative. And so we, after this, we went for the hyperemic induction with intravenous adenosine. And we can see here a negative value of the FFR of 0.94, and also negative value of CFR and IMR of 5.7 and 14 respectively. So at this point, what we have seen is that there is no epicardial disease, but there is neither microvascular dysfunction. So what should we do? Should we stop right now? Absolutely not. What we have to do is going forward and assessing for vasomotor disorder, and so that's why we decided to perform acetylcholine provocation test, and this is our protocol for intracoronary acetylcholine, which is a safe and effective way in order to assess vasomotor disorders. And as we can see here, when we perform intracoronary acetylcholine, what we want to see is that if there is coronary spasm more than 90% on the angiography, if there is of chest pain, if the patient starts experiencing chest pain, just like he felt at home, and if there is some HEG changes. In this case, also in step 1, we had some HEG changes right here without not having neither coronary artery spasm nor chest pain. So at this time, we decided to go for step 2. And step 2 evaluation revealed both chest pain and epicardial coronary artery spasm. As we can see here in the angio, there is an evident spasm of the LAD, and the patient starts experiencing chest pain with some modification on the ECG that was just present at step 1. So all the 3 criteria have been satisfied right here. So we decided not to go for step 3 and to stop here with our test. And we injected some nitrates in order to relieve the spasm. And as we can see here, the spasm has been relieved thanks to the nitrates. So if you want to make a brief recap, the RFR and FFR assessed the epicardial vessel with both negative values, so we excluded the epicardial disease. And at the same way, the IMR and the CFR excluded the microvascular dysfunction with 2 negative values. But the intracoronary acetylcholine test revealed a vasospasm of the epicardial vessel and especially of the LAD. And so, of course, thanks to all this data, we were able to achieve a correct diagnosis, understanding the right pathophysiological mechanism that was underlying our patient's symptoms. And of course, we were dealing with vasomotor disorder of the LAD. And so we know that vasomotor disorder, so not only we achieved a diagnosis, but also we had some therapeutic options. And as we see here for vasomotor disorder, we both have medical therapy and lifestyle factor therapy. And this is the therapy the patient was doing before of the cath lab. And in these cases, the most important things to do is withdrawal of beta blockers, because as we know, they can provoke the spasm. So we removed the beta blockers. We also, started some CCB, some central CCB, and we optimized the therapy with statin. The patient was then discharged with this therapy, and of course, we saw the patient back at 6 months follow-up at our outpatient clinic. The patient felt really, really better, so he had no more symptoms, and he was stable. He kept on, complaining some rare episode of angina, but he was quite happy about his condition. The SAQ score improved from 56 to 79, so he has no more palpitation, and he did not limit anymore his daily life activities. So, if to go back with our take-home messages, what we have to see is that both epicardial and microvascular circulation can have some structural and functional disease. And so what we should do is always, go further the assessment of the obstructive epicardial CAD. Because, of course, both the epicardial and microvascular disease can have some spasm, can have some structural damage, can have impaired vasodilation. And it's really important to really understand what is the exact pathophysiological mechanism underlying the condition, because for each of them, we have a different therapeutic option, and being able to, give some therapies, of course, the patient can improve his symptoms, improving his quality of life, and of course, we can provide the patient with a better prognosis. In order to do so, the full physiology assessment is a systematic step-by-step assessment that, allow us to evaluate each component of the coronary artery tree, so from the epicardial to the microvascular. And what we should understand is that it's not important to perform every step. So not every step is mandatory for every patient. But what we should do is performing a sort of a tailored assessment based on patient symptoms and patient situation in order, to provide the patient with the best treatment option. So thank you very much, everybody.
So thank to you, Andrea. Really nice case, and here we saw our full physiology approach changed the diagnosis of the patient and so the treatment. And I'd like to ask to Simone what you think about this specific case, and in general, which is his approach for ANOCA patients.
Yes, I would like to make 2 points. The first is that as you have seen in this case, it's not that vasospasm or microcirculatory disease is a distinct entity rather than CAD. So, because in this case, this patient had some plaque on the LAD. That was actually the point in which the spasm was occurring during acetylcholine. And this is actually very, very interesting because there is a beautiful paper published on Art last year that showed basically that if you follow up the patient with the spasm is a huge driver of CAD progression. So it's not that you have to think about a completely healthy patient without any other issue, because sometimes it's the patient you perform PCI on 2 or 3 months before, just because of the inflammation and the the stimulus that is given by the PCI and by the presence of the stenting is a trigger for spasm in the non-stented segment of the artery. So it's not something that we should think of as the last resort in 2 cases per year. It's something that can happen also in the patient we deal with in clinical practice. And the second point I would like to make is that not performing a proper diagnosis is not an innocent thing, because in this case, what we did after we did, not myself, but someone did it, after the first coronary artery angiography, is to put the patient on beta blocker and worsening the symptoms and the quality of life of the patient. So again, it's not that, I mean, I will try some drugs and then we'll see what happens. It's not like that. Because in some cases like this one, these action actually worsened the quality of life and was basically harmful for the patient.
Yes, absolutely. Thank you. So if you have any question, please type in the chat. We have already one question from Giulia Masiero, and this is goes directly to Simone because of his expertise. And can you give us some practical tips and tricks during the functional evaluation, especially with the acetylcholine test?
Yes, for sure. So basically what we do is always to do it with a guiding catheter in place and the pressure wire down the vessel. So this is, I think, is the safest way to perform physiology and acetylcholine test. So what we do is to go on the left side, never on the right. There are few cases in which you can think of going to the right, but it's not, I think, the go-to strategy for each case. So what we do usually is to do on the LAD. So we put down the pressure wire and we perform the full physiology assessment, namely epicardial and microcirculatory assessment. You can do it with the IV adenosine or with the intracoronary papaverine as you prefer. And then afterwards, you wait like 30 seconds to 1 minute. You can start with the 3 steps of acetylcholine infusion. And then when you do it by injecting intracoronary the first step, each step of the acetylcholine test. So 20, 50, 100. We usually don't go to 200. Somebody else is usually doing it. It's up to you. But basically what we do is to infuse in 1 minute each step. And the only thing you have to check while performing the infusion is the cardiac frequency of the patient, because in some cases you have bradycardia. And so if you perform some bolus infusion and you're not careful in performing a steady infusion of the drug in 1 minute, 1 minute and a half, you may have some very short pauses, because as you stop, the pause will stop because the half-life is 1 second. So basically, it's really, really immediate, the improvement of the cardiac frequency. So just if you try to take into account all those things, it's a very smooth evaluation that takes no more than 5 minutes.
Thank you. And one question related of this the protocol. Have you ever experienced any dramatic complication or major complication during the test? Because a lot of people maybe are scared about this.
Yes, I think no dramatic complication. We had 2 cases with atrial fibrillation. but we did more than 100. So it's, I think, a very, very low percentage of patients, and it was not sustained in one case. So it was like 2 minutes or 2.5 minutes. In the second one, we had to perform the bolus with amiodarone, and then it was okay. And no other major complication. The only thing you have to deal with is dealing with the cardiac frequency of the patient, and especially at the 100 steps, so the third one, you have to be careful, and maybe in some cases it may take you 3 minutes instead of one to infuse the drug, because otherwise the patient will have pauses or at least bradycardia. But then you go very, very smoothly. The fact that you have already the catheter and the guide down the vessel is extremely reassuring, at least for me. And then the other thing you have to take into account is that when you have also a occlusive spasm with the usual nitro that you perform in each case, it will respond very, very well. So you will have the complete resolution of the spasm within seconds. So it's not something that will last long when you have a positive test. As soon as you perform nitro, you have always to remember to have nitro on the table, not to start thinking about nitro when you see the occluded coronary artery. But otherwise, it's a very safe evaluation.
Thank you. And one question to Andrea, because these patients are frequent flyers of the ambulatory, have you scheduled follow-up for this kind of patients in your institution?
Yeah, thank you, Marco. Yes, we do used to follow these patients with of course magnetic resonance. In this case, the patient performed the CMR before for other reasons, but we usually go for this patient to perform a CMR, and then it depends by case. Of course, if we have the suspect for other disease, we can also perform intracoronary imaging and in the cath lab. What we usually do in these cases is just try to perform the diagnosis at the same time of the procedure. So we do not usually do all these evaluation in separate sessions, but we used to perform all in one session in order to provide the patient with diagnosis in one time. So this is our protocol in most of the cases. I don't know if Simone wants to add something more.
Yes. The follow-up is a very important point, and it's a very interesting question, because basically in those patients, the usual doses, if we speak about, for example, patients with vasospastic angina at the epicardial level, the usual doses of calcium antagonists may not be enough to properly control symptoms. You saw that after 6 months follow-up patient, our patient still has some kind of discomfort, small episode of short episode of chest pain. So what you may have to do is to titrate calcium antagonists through time. And this is particularly important to have a diagnosis, because otherwise it's impossible to go to high doses of calcium antagonists that may cause adverse effects, because you know that if you go up to very high dosage of calcium antagonists, you will have some kind of adverse effect. And so you have to inform very well the patient regarding the fact that you are doing it because you have a clear diagnosis, and because this will be the way for him or for her to have an improvement in symptoms. And so it's important to follow up those patients in order to understand that what you are doing is controlling their symptoms properly. But the idea is to control clinically, not to have any other, invasive assessment. Otherwise, obviously, some new symptoms are developed, and you think that something may have changed.
So, thank you. Another question: if you have a patient with a suspected vasomotor disorder, do you think that a non-invasive assessment like coronary CT plus FFR and empiric therapy could be enough for these patients? There is other tests you can do before send the patient to the cath lab. This question came from the chat from Antonio Soropago.
Yeah, it's a great question. So I think that you may have the possibility to avoid some of the invasive assessment where everything is negative, but the issue, if the CT-FFR and the CT and CT-FFR are negative, you can tell the patient you don't have a cardiac disease, but then if the patient is still complaining symptoms, you have to do something. I mean, you can try to wait a little bit more, so you will have some patient actually uh, being good after a negative reassurance given by CT and CT-FFR. But if there are patients with vasospastic angina or with microcirculatory disease, those patients will continue to have pain to be. So basically, right now we don't have. I mean, you can do some kind of evaluation of the microcirculatory system with the cardiac magnetic resonance, and this can help you. But I think that in order to have, a complete assessment of the circulation, one invasive procedure is the best way to do so. But I mean, in some cases, it can be that you have to perform, CT, CT-FFR, and then you perform CMR, and you see huge microcirculatory disease, and you can start by dealing with it and see what happens next.
Thank you. So, because of this resistance to do all this full physiology evaluation, what we need in terms of evidence to convince more people do all the evaluation? What have you any insight or anticipation of paper or evidence that are coming that could convince more people to do a border investigation?
Data basically is there. If you want to
Okay.
see them, they are already out, because I mean, also Cormica, that can be a little bit tricky to evaluate and to understand. But in Cormica, basically the message is if you give the patient a diagnosis, the patient will be better, because the tailoring of the therapy was not so good. So basically, they just tell the patient, I mean, this is your issue. You have to deal with it. I will try to help you in some way. In some cases, good, in some other not. But this was the first point. And then there is the beautiful study that is the CHAMP CMD that was published this year, in which they perform a blinded assessment of CFR and IMR in patients, and then they perform a double-blind randomization with amlodipine and ranolazine, and they performed treadmill tests at baseline and at each step after each drug and after the withdrawal of the drug. And what they saw is basically that the improvement in treadmill performance was present only in the patient with CFR and IMR reduced. So again, if we avoid to perform a diagnosis and we give all the patient, all the treatment, is not good, because there will be patient doing drugs for no reason whatsoever. So again, if you perform the diagnosis, we are starting to have some evidence on the therapy. You know that you can perform a very aggressive secondary prevention in the setting of microcirculatory disease. You have to stop beta blocker and start calcium antagonists for vasospasm. You have ranolazine, you have amlodipine. So basically, there are drugs that you can use. Obviously, we need, and Serena is doing a very beautiful study at our institution, following up on patient with microcirculatory system and giving them a broader assessment and broader, treatment than drugs. So they are performing physical activity, they are performing psychological help with in order to cope with their disease, because these are patients that will continue to have some symptoms. So you have to explain to them. They have to perform physical activity. That is probably the best drug they can take. And so we will see the result of this study. But in general, I think that Also, what we did with the reducer is an indirect demonstration that you can change the microcirculatory dysfunction, because what we did with the reducer was to perform CFR and IMR at baseline before reducer implantation and after 4 months. And basically what we saw is that patients with the high IMR and low CFR were the ones having the best improvement in CFR and IMR at the follow-up after reducer implantation. And reducer is basically just redistributing flow, from the to the epicardial from the epicardial to the endocardial part of the myocardium. So, I mean, we have many things that we can do for those patients.
So thank you very much, Simone, for all your comments. Very useful, and thank you, Andrea, for your case presentation that show us how full physiology approach changed the diagnosis and so the therapy of your patient. So our 8 in the morning. So I want to thank all of you that participate to this session. And here there is a save the date for the next episode that will be on 24th of May. The topic will be cardiogenic shock challenges. So see you in the next episode, and have a good day and good weekend to all. Thank you.
Thank you, Marco. Thank you, Simone. And
Thank you.
to all of you.